This is Dr. Andrew Young from the Center of Hip and Knee Replacement in Santa Monica. And for this video, we're going to step back from the technical aspects of surgery and talk about the perioperative management, specifically the management of Plavix. The generic name is clopidogrel, so the management of this blood thinner in the setting of hip and knee replacement. So let's step back and talk a little bit about health and biology. So many patients with arthritis are older, and many older patients have pre-existing conditions like cardiovascular disease. Some patients with severe cardiovascular disease will require cardiac stents to maintain the flow of blood to the heart muscle. And if a patient has cardiac stents, they will often need to also be on anticoagulants or blood thinners to make sure that blood continues to flow smoothly through these stents. And the most common anticoagulants in patients with cardiac stents is Plavix and aspirin. Both of these affect platelets, and so this is called dual antiplatelet therapy. So clopidogrel, we'll call it Plavix throughout this video. These are the same thing. This is the trade name. This is the generic. They mean the same thing. Plavix is an antiplatelet medication used to prevent the clotting or the thrombosis of these cardiac stents to prevent clots. So it's very important to maintain the health of the heart. But you can see the problem that we're facing in surgery. As it keeps the blood very thin and prevents the development of clots around the heart, it also increases the risk of bleeding at the time of surgery. So now we're on a tightrope. We're trying to prevent clots from developing in the heart, but we're also trying to minimize bleeding that naturally occurs after surgery. And so how do we deal with this? This has been one of the most challenging questions in the perioperative management. How do we deal with blood thinners in the setting of elective hip and knee replacement? So we're trying to keep the heart safe, but we're also trying to keep the surgery as safe as possible. And so we accept that there are trade-offs. Now, historically, patients have always been taken off their Plavix to minimize the risk of bleeding after surgery. But at the same time, we knew there was going to be an increased risk of potential heart problems. And so these surgeons began to reevaluate the questions. Then the actual genesis of this question came after two patients who were taken off their Plavix had heart attacks prior to surgery. And so they began to think that the risk of bleeding was far less significant than the risk of a fatal thrombosis. So they began to explore the possibility of continuing Plavix in the setting of joint replacement and then look at their data. So this study becomes a very important set of guidelines of how we might approach a patient who needs a joint replacement and is also on Plavix because of cardiac stents. So before we dive into the paper, again, we're looking at the essential question. In managing anticoagulants, do we continue the Plavix or do we stop the Plavix? The essential question is, how do we balance cardiac safety versus surgical safety? How do we balance the risks to stent thrombosis into the heart versus the risks of bleeding into the wound in the setting of surgery? In this complex set of patients who both require a joint replacement and have elevated cardiac risk factors. So what our surgeons in Tampa did is they looked at 158 patients who were both on Plavix because they had stents and needed joint replacement. And they divided them into two groups. One group continued on Plavix and one group had their Plavix held. And they looked in the difference in outcomes, specifically in the potential rate of complications between the two groups. So let's just take a brief look at the materials and methods or their study design. So the surgeons in Florida looked retrospectively, they looked backwards at the patients they treated who needed joint replacement and who were on Plavix during the years 2016 to 2020. And they noted there are 158 total patients on Plavix who required a joint replacement. And they divided these into two groups. 66 of these did not have the Plavix held, 92 patients had the Plavix held. And then they compared the results of these two groups, those that did not have it held and those that had it held. So those were their independent variables, and their dependent variables. For their primary endpoints, they looked at two sets of endpoints, primary and secondary. They looked at the receipt of transfusion between the two groups and readmission, or needing to come back to the hospital because of a complication after surgery within 90 days. And they also looked at things like bleeding, infection, reoperation, major cardiac or neurologic events. They just looked for the presence of complications and the difference between the two groups. And a very interesting thing is that they found very little differences between the two groups, between the group that continued on the Plavix and then the group that was taken off the Plavix. And so it turns out intraoperatively, they had very similar characteristics in terms of blood loss, time surgery, and all those other factors. But this is what we're really focusing on. Does the continuation or the holding of Plavix increase the risk of complications on either side? And they really didn't find any significant increase in risk, except for a statistically significant increase in the rate of blood transfusion on Plavix. But I'll show you the details more closely. Now, when we look at these results and we look at this chart, remember the big picture. So there are a lot of numbers, but remember the big picture. The big picture is we're trying to balance the risk of a fatal complication by coming off the Plavix versus the increased risk of bleeding if you stay on Plavix. So again, we're trying to balance the risk of a fatal thrombosis by coming off the Plavix versus the risks of bleeding and complications by staying on the Plavix. And so I'm going to draw your attention to this bottom half of the chart. And they looked at transfusion, wound drainage, wound infection, antibiotics. And this just shows us there was no difference between the two groups. So it was safe in this group of patients to continue Plavix in the setting of surgery. It didn't increase statistically this rate of complications. However, they did find that patients on blood thinner had an increased risk of requiring a blood transfusion. Now, getting a blood transfusion is not benign, but again, the whole point of this process was to try to prevent death by coming off the Plavix prior to surgery. So they had an increased risk of transfusions, so 6 versus 0, but at the same time, they didn't increase the risk of other complications, and there was not an increase in mortality that was statistically significant. So the importance of these studies is that they're guidelines. They're not telling us what to do. They're giving us information about other potential pathways to manage patients on antiplatelet medication and who also require joint replacement, because there is no definitive mandate on which way to proceed. And so they're giving more information so that the surgeon and the patient and the cardiologist can make better decisions together. And according to this study, so now we have data, we're not just going based on opinion, patients proceeding with elective joint replacement can continue Plavix throughout the preoperative, intraoperative, and postoperative process. It is not mandatory based on this study that they continue. And why? Because all patients are different. Some patients may have underlying clotting disorders. Some patients may have more than one stent. Some patients have multiple stents. Some patients have stents in parallel. Some patients have stents in bifurcation. So even patients with stents have different levels of risk regarding thrombosis. And so now this study allows cardiologists and surgeons and patients to make a better decision together. And again, what they found is there was no statistical difference in many of the complications, but they did see a difference in the number of transfusions. Now, most people did not require a transfusion, but there was an increased likelihood of the possibility of transfusion if a person was to stay on Plavix throughout the perioperative period. And for some people, that may not be worth it. But for some, the risk of transfusion may be an acceptable risk if it decreases the risk of a fatal thrombosis. Now again, this is just one study, and it was only 158 patients. But this study now adds to the body of literature looking at the continuation of Plavix. This study by Ganem that came out in 2017 was an important study because it looked at the continuum of Plavix in non-elective joint replacement. So these are patients that had hip fractures. There was no time to have them come off the Plavix, so they needed immediate treatment. So the surgeons here were stuck. They were on Plavix, and they had a fracture, and it needed to be treated with a joint replacement. And they found these patients did just as well. And it's papers like this that began to open our eyes to the possibility of continuing Plavix rather than mandating that they come off. This was a Cochrane database study. This is a assimilation of multiple studies that are non-cardiac, so orthopedic, GI, general surgery, looking at discontinuation or continuing, and they felt that it was safe based on this literature. And another study looking at continuing Plavix. And all of these papers support the possibility of continuing Plavix as a reasonable option in specific patients. But again, these are not mandates. These are just something that you should discuss with your cardiologist, your surgeon, and with your family to figure out which risks are most acceptable to you. So again, we're going back to our essential question from the very beginning. How do we manage anticoagulation, specifically antiplatelet therapy, in patients who have arthritis, who require joint replacement, but also have stents and are at increased risk of stent thrombosis? Do we stop the Plavix and increase the risk of stent thrombosis or fatal thrombosis? Or do we continue to increase the risk of blood transfusion? There is no easy answer, but this type of study shows that either of these is a possibility depending on patient characteristics and patient preferences. If you want to go deeper into the study, I'll refer you to the Journal of Arthroplasty, and then you can read through the article. And then you can also let your cardiologist or your surgeon know about this article.